Thank you, Dr. Zamakhshari. Our next speaker in this session is Dr. Yasser Khan. He's an experienced health informaticist and pediatrician. He received his medical training from University Hospitals of Leicester. In parallel, he worked for a master's degree in information systems where he was awarded gold medal for his work in medical informatics. He briefly worked as a researcher at the University of Huddersfield to pursue his research interests in the field of virtual reality and its clinical uses and published his work. He's had several medical informaticist positions within the UK as well as within the Middle East, and he currently serves as regional challenges. He currently serves as the physician executive for BMJ Evidence Center, focusing on the Middle East, and he continues to serve clinically part-time. Please help me welcome Dr. Khan.
Thank you very much. How should I switch to slides? Assalamu alaikum, everyone. Really grateful to KFMC for giving us an opportunity to come and present and attend some of the really interesting presentations. We'd just like to start the presentation in the context of innovation with the quote that application of what we know already will have a bigger impact on health and disease than any other drug or technology likely to be invented or introduced in the next decade. Basically, what we are trying to say is what we already know can be applied in a smarter way, in a much more efficient way, to have a much more better impact on the disease outcome. So BMJ, we have a history of 170 years of supporting excellence in clinical practice. Everyone very quickly associates BMJ with BMJ Journals. It's a journal that comes out weekly, and we do have 42 titles of these journals. However, as the industry has progressed, we have moved into new areas where education, BMJ learning, master classes, Informatica, which is around the business intelligence and influencing clinical behaviors. And last but not least is BMJ Evidence Center. And this is where the clinical evidence products and clinical evidence is evaluated and packaged into different products that me and you can use at the point of care. So how do we do that? If you open a black box of BMJ, what do you see? You see the heart of BMJ is Evidence Center, Evidence Engine. Evidence Engine consists of people, processes, tools, technologies, 100 of doctors who are practicing doctors, and they all come along to do research, automated research, horizon scan, guidelines, and drug alerts, and then filter them according to established criteria, then do a particular appraisal for their quality, grading of these evidence base, and then do a synthesis, interpretation of that evidence, which is relevant, and its evaluation for its quality, and data extraction from different databases, clinical registries, and last but not least is developing into meaningful use of evidence summaries which can be utilized at the point of care. And that constitutes our evidence engine. So these are the inputs of our evidence engine. What is the output that comes out of it? We'll just quickly show you what we do. That we present it into clinical audits and alerts. We develop them into something which you could use to measure quality of care, clinical rules, alerts. Decision support is another area that produces evidence-based order sets, referential resources, some IBM tools, calculators, patient informations. Then we were into learning, which is e-learning, need assessment, face-to-face meetings, and simulations. And then we have services, which is around health technology assessment, health economical analysis, benefit case realizations, and evidencing. So these are the 4 different areas that actually has provided an output from our evidence engine. So what is the case for clinical decision support? And for a second, if we diverge away from the clinical scenario and look at other industries, as an example, let's take an example of airline industry. This is Boeing 299, 1935, really a fantastic design, going through its final phases, took off, and that's what happened. So investigation showed the pilot was unfamiliar with the aircraft and neglected to perform a critical action before taking off. Some newspapers even wrote the whole design off and say it's just too much of a plane for one man to fly. The pilots came together, they developed first decision support tool, and it was in the form of a checklist. Airfograph was just too complex for anyone's man's memory to do all those checks before the plane is actually ready to fly. Aviation industry since 1935, have used checklists extensively. So what clinical decision support can do for in a clinical scenario? Let's look at the use cases, some of the most obvious use cases. It can help you drive evidence into practice. It took 200 years before the Royal Navy routinely starts using lemon to prevent scurvy. First study was published 1601. They weren't using it until 1800s. Routine use of thrombolytic therapy in an acute myocardial infarction, early 1990s proved that. And first RCTs that actually showed the efficacy was 1950. So 40 years it took us to actually start using routine thrombolytic therapy for prevention of MI. And similar examples exist. On average, it's been quoted, it takes almost 17 years before an established evidence find its way into clinical practice. And let's not forget the burden of evidence is significant. So these are some of the figures that are plucked from the literature. And if you just look at the data, it's 120,000 RCTs per year get published. As a lead clinician, if you do want to keep it up, it's kind of impossible for you to just keep it with your area of expertise and then reflect that into your clinical practice. Almost 500,000 articles per index in PubMed every year. So what's the impact on recommended care? Some of the literature shows that Americans on average receive just 54.9% of recommended care. And adherence to guidelines can be as high as 78% in some cases and can be as low as 22%. And that's where the clinical decision support can really help you develop workflows which reflect the recommended care. In terms of quality, now there's some really dramatic figures coming up now. Clinical decision support is greatly associated with the reduction of inpatient mortality. And the top figure for CABG, 47% reduction in mortality when the clinical decision support was introduced. In terms of cost efficiency, now if we are aware of HIS implementations and benefits of HIS, but let's look at if we are to just automate test results, how much money you could save per patient per episode, and that's $110 per patient per episode. If you are to automate order entry, so you have a fully working CPOE solution in a hospital, you probably can save $132 per patient per episode. But even top of it, if you have a clinical decision support working for your CPOE, your saving from that implementation is almost 4 times. It's just a huge jump from $132 to almost $600 per patient per episode. So what are the 4 critical factors of clinical decision support and its success? It's quite important, so I like this slide because it shows that when you actually have computer-based generation of decision support, and that's the lowest level that you can aim for, any intervention you design around that is 6 times more likely to succeed. If provision of decision support is available at the time and location of decision making, and that can be something as simple as somebody is just handing over a guideline to you at the point of care. Well, you're treating a patient of chest pain. This is a guideline, point of care presentation. Your intervention is 15 times more likely to succeed. But if your decision support is part of your workflow, it's automatically become your part of workflow, there is no circumvention to that, there's no workaround to that, your intervention will become 112 times more likely to succeed. So while this is all good from the theoretical point of view, let's look at the solution and design a solution for a multifaceted problem. And the way we try to address it in 3 very easily understandable steps, you would enable your workforce, you would empower your workforce, and you will develop your workforce. And what do I mean by that? Let's take first step, which is let's take an example. You have a problem of chest pain management in the scenario of A&E. First step is introduce active decision support. What is active decision support? It will have an immediate impact. This is a decision support that actually is part of your workflow. It includes your evidence-based order sets, your care pathway, your clinical rules, your alerts, your drug checking. And this is something which holds your hand and asks you a question: do you really want to do that? Do you want to review your medication profile on this patient? Have you forgotten doing this and these steps? And this comes in as part of your workflow. So that's the first part, which enables your workforce to check their practice against the best practices. And just giving you an example, this is a patient who has come up as chest pain, 57-year-old, Mr. Robert Hamilton, and he's been started on action set or an order set, which is evidence-based, and it has different phases. And let's examine, there are almost 100 to 200 different orders on this order set, which go into an nth detail of how this care should be administered. So in terms of medication and IV fluid requests, in terms of patient care, and goes to a detail that it doesn't just say, give this patient diamorphine, and let you or anyone who is giving care try to guess what the dosage would that be. But actually goes into nth detail of 2.5 milligram IV injection for 4 hours. So there is no ambiguity of interpretation between two people giving the same or utilizing the same order sets. Going forward, again, you have pathology tests, you have diagnostic tests, even down to what other team members in a multidisciplinary environment should be involved with this care. And that's a kind of active decision support that would have an immediate impact on the quality of care you're delivering. Let's look at the second step. So first step was enabling your workforce. Second step, empowering your workforce. And by empowering means you don't want to just give them a tool for point of care, you also want to empower them with the knowledge that backs it up. And that is the passive decision support. In the passive decision support, you have updated evidence-based detailed information designed for point of care utilization. It's meant to provide knowledge refresh and supplementation, and it doesn't have to be all consumed at point of care. We all know how any departments can be really busy. You don't have to utilize all the detailed information at the point of care. You could save now and learn later. Ease of access and navigation is important. One of the studies quoted, by observing clinician behavior, that for an average, a clinician spends less than 20 seconds looking for relevant information before giving it up and moving on and trying to utilize his own memory and own capability. So guidelines, expert advices, case studies, and journals all part of the detailed information, and they have to be presented in the way that it can be utilized in a meaningful way. So again, what do I mean by literally on the ground is we are in the same situation, we are on order set for a patient, but at this moment, I actually want some more information about what kind of, order set has asked me to do an ECG, but I need more information. What I'm looking into that ECG, I click on a link and it takes me to a snippet of information to say, you've done an ECG, you need to be looking for Q-wave inversion, you need to be looking for your T-waves, you need to be looking for other areas that there may be a finding there. And this is a very quick way for me to check my knowledge. But if I wanted a much more information and I'd say, well, this is my patient with chest pain, but however, it doesn't look like this patient is actually having a myocardial infarction, I could go for a further detailed information right from my point of care workflow, which is going to best practice. What are my urgent considerations? Am I missing out anything? What are my differential diagnoses in these cases? I know about acute coronary syndrome. However, what I didn't think about is pulmonary embolism. Let's look at pulmonary embolism. And in this case, what are the findings should be in my history? What the things I should be looking at my examination? And what are the first and second line of tests should be, and what the outcomes of those should be? So these are things which are available to me at the point of care. And I could go on and actually consult these resources. So now we're down to the third step. So one was the enabling, then the empowering, and then third one, developing your workforce. So structured learning. And I refer back to the same workflow. At the back of the screen, you could see the same EMR being opened. However, now the point of care reference database refers me to BMJ Learning, where I have access to almost 550 learning modules. And this is learning module that I could see, and it says acute chest pain, diagnosis and management in association with heart. And what I could do at this stage, let's example, I have time at the moment, I'm not rushed, I could start this module, and it tells me what my learning outcomes would be. It gives me a pre-test to just test my knowledge on the subject before the learning module is being completed. It would also offer me something after that just to test if I have improved my knowledge, if I'm likely to treat my patients better based on the knowledge gained. And at this stage, I actually don't have time, so I can I can bookmark it by using add to my portfolio, and this is something which is designed for individual use. I could add that, and that's something added to my portfolio account. Later on, I can go back to it and say which ones I actually added and have not completed, and I have acute chest pain on the top, and I can start utilizing them. So by utilizing 3 really off-the-shelf order concepts, which is A, active decision support, B, passive decision support, and right all the way linking through to learning, what I have done is I have identified a particular workflow that I need to improve. I've identified a particular clinical area that I need to address, and I can start addressing them quickly and easily. And the cycle of clinical improvement continues, and I can move on to a next area, or I can concentrate on the same area while aiming for a different outcome. So in the end, what I want to leave you with is the 5 rights of clinical decision support that we would like to aim for is right information to the right person in the right clinical decision support intervention format through the right channel and exactly the right time in the workflow. And the 6th one that I've added is you are aiming for an earlier impact on the workflow with the durability of the change. Thank you very much for listening.